Good evening, friends, and a warm welcome to this edition of Diabetes Essentials, sponsored by FDC. Each week, we choose a different topic to talk about, to discuss. This week, we'll be choosing a topic that is so simple that we forgot to discuss it last year. But it is a topic that is of relevance. It is a topic that is of importance to each and every person who prescribes insulin, each and every person who takes insulin. So today we'll talk about insulin technique and also troubleshooting in insulin techniques. Why do we need this troubleshooting? We need it because sometimes things can go wrong. Sometimes the technique can go wrong. And why do we need to learn technique? Because if you don't know the way of injecting, then how will you inject? So before you start an insulin therapy, any injection therapy, you should know that you understand and you should know that your patient understands each of these things. What regimen is being prescribed? What are the number of doses per day? What preparations are being used? What is the preparation? Is it fast acting, rapid acting? Does it have to be given with meals, before meals, or along with meals? Is it slow acting or basal? Does it have to be given at night or can it be given at any time of the day? Not only do we have to know the regimen and the preparation, we also have to know the concentration. The insulin that we've prescribed, is it a 40 units per ml or 100 units per ml insulin? With which syringe or with which pen is it compatible? So we need to know the insulin regimen, the preparation, the concentration, and also the device, because a particular device will be compatible with a particular injection. Not all of them will be compatible with each other. Once we are sure about that, then we need to see whether the device and the insulin that we are using is correct. Is it the right insulin preparation, the right device? We hope it's not expired. We hope that it's not spoiled. You do a visual examination and make sure it's okay. Check if there is air in the device. Check if the needle is correct. So all these things also have to be taught to the patient. Then we talk about injection technique, choosing the right site, choosing the right angle, and ensuring that the insulin goes into the subcutaneous tissue, not intradermally and not intramuscularly. Then we talk about troubleshooting. What are the possible complications? How do we avoid them? How do we choose the right needle? And then how do we dispose of it? What are the anxieties and concerns, the complaints linked to insulin therapy? All these are things that the patient has to talk about. And all these are important because without them, you will not be able to use insulin properly and you will not be able to achieve good glucose control. So let's talk about this today. How do you choose the right device? You have to individualize based upon the patient's needs and desires, also skill level, also availability and affordability of devices. For all of you, what I would suggest is that you choose any one device that you use for the vast majority of your patients. You might wish to use needle and syringe. You might wish to use pens. Pens can be disposable, they can be reusable. Whenever you start an insulin, initiate, it is easiest in my experience to start with a disposable device. So the patient buys one pen, a disposable one. He uses it or she uses it for a week or 10 days. Then you see the comfort level. If you feel that insulin will be given for a short period of time, maybe just to cover an episode of diabetic foot, then you can continue with disposable devices. If you feel that insulin will continue for a long period of time, maybe indefinitely, then you can get the patient to shift to a reusable pen, which will be cheaper. But in the first instance, on day one, start a disposable pen because your patient may not feel comfortable with that device, with that insulin regimen, with that insulin preparation. So next week, you always have the option to change. There will be some patients who will not feel comfortable with a pen or who will specifically ask for a, a needle and syringe or will ask for something economical. In such cases, you can actually use a needle and a syringe and vial to help them get economical insulin. Be aware also of all the various manufacturers of insulin, and do spare time to talk to your chemist, to talk to your pharmacist and see the various costs. There is a wide variation in cost of human insulin as well between different manufacturers, and there is a wide variation, of course, between human and analog insulin. So be aware of the cost, availability, affordability, and speak with your patient before prescribing. But like I said, choose one method to begin with in the vast majority of your patients. I would prefer to start with a disposable pen on day one. And after a week or 2 weeks, then we reinitiate the discussion and then we discuss what to do as we move ahead. There is something known as VAT, not value added tax. This is value added therapy. Value addition to insulin will occur only if you educate the patient, train the patient, and you have to keep on doing this continuously. It is not enough just to do it once. You have to keep on doing it regularly. So at each visit or even remotely, you have to keep on talking to the patient about insulin technique. This is especially important if you wish to initiate continuous glucose monitoring or automated insulin delivery early in the treatment of diabetes. But in the vast majority of patients, we prefer insulin syringes and pens. Like I said, I prefer pens. In many centers, syringes are used. In general, it will depend upon the cost and upon self-management capabilities. But it also depends upon the time taken to teach. 3T, time taken to teach. 4T, time taken to teach technique. What we have seen in our hospital is that it takes less time to teach about a disposable pen than it takes to teach about a syringe and vial. So be aware of that. If you're working in a busy center and time is of importance, your assistants, your diabetes educators are overworked, then pens are easier. Also, pens are easier to use for people with dexterity issues, those who have difficulties with counting, with seeing, and with using their hands. Of course, insulin pens are more convenient and more accurate, but they also have a smaller gauge of needles. So therefore, they cause less pain. They are less intrusive, easy to carry around, and socially more acceptable. So therefore, they are more flexible to use. Insulin syringes, however, are flexible from a different point of view. Whatever the manufacturer of insulin is, you can always use that with a syringe. It just has to be a 40 unit or a 100 ml, 40 unit or a 100 unit per ml syringe. That, of course, you will have to check based upon the insulin concentration. It's much easier to read the numbers and the scale lines on the insulin syringes, so some people prefer that. And with insulin syringes, you can choose the kind of regimen that you want. For the traditional ones like premixed, prandial, and basal bolus, you can use either a pen or a syringe. But if you want a split mix regimen, then you will have to use a syringe and vials. Cost, of course, is an issue. Syringes and vials in general will be less expensive than pens. Once we've chosen the right insulin device, the right insulin regimen and preparation, then we begin teaching our patient about techniques. Now, some things are common. The patient has to wash his or her hands, check the expiry date of the insulin, ensure that the insulin is right. You have to teach your patient to know whether the particular insulin is cloudy or is clear solution. Most insulins are clear, but NPH is cloudy. Therefore, NPH will be cloudy, and any other insulin that contains NPH, like premixed human insulin, biphasic aspart, and Lispromix, these will also be cloudy. But apart from that, all the others will be clear solutions. Bring the insulin to room temperature. If you've kept it in the refrigerator, take it out half an hour before injecting. If it's a cloudy insulin, roll the bottle between your hands 10 to 20 times until it has become uniform. If you're using a syringe and vial, draw air into the syringe equal to the dose of the insulin you wish to take. Insert the air inside and then take out the insulin. Whether you're using a syringe and vial or you're using a pen, Make sure that there is no air. Make sure that you've taken the right dose or dialed the right dose with pens, and then you inject. Where will we inject? We have to choose the right site. So we'll talk about that, but the preferred site is the abdomen or the upper part of the thigh. Now, you can take a skin fold, but you don't have to press it very hard. The skin fold is actually meant to make sure that you enter the subcutaneous tissue. In general, the thickness of the dermis is about 2.2 millimeter. So if you have any needle which is more than 2.2 needle millimeter long, you will be able to enter subcutaneous tissue. Subcutaneous tissue depth is dependent upon gender and upon age. Women have more subcutaneous tissue, children have less subcutaneous tissue, adults have more. So, based upon the patient's age and gender, and also physique, you may wish to make a skin fold, and you may wish not to have a skin fold, because all you have to do is to ensure that you enter subcutaneous tissue. If you go too deep, then you end up entering the muscle, intramuscular. What will happen? Any kind of insulin that is given into the muscle will act like a rapid acting insulin. So even if you give glargine, that will also become a rapid acting insulin when it enters the muscle, and patient may go into hypoglycemia. Now that you've injected, you have to make sure that you dispose of your needles and ancillaries properly. So that's also you have to teach the patient how to dispose. We said we would talk about the site of injection. The site is usually the abdomen. Stay 3 fingers away from the umbilicus, both left and right. So leave the periumbilical area and inject anywhere else. You can divide the quadrants of the abdomen. You can divide the abdomen into 4. So every day you inject on a different quadrant. Ensure that you are at least 1 finger breadth away from the previous injection. So keep on injecting at different places so that there is no lipohypertrophy. We'll talk about that later. In the thighs and buttocks, you can divide into 2 on each part, and that will also help you decide where to inject. A simple way which I use to speak with my patients: for the thigh, you find the bony prominence, that is the anterior superior iliac spine. Find the bony prominence in your pelvis in front. Find the prominence of your knee, the kneecap. This length you divide into 3 and try to inject in the middle 1/3 on the lateral side of the thigh. In the medial side, there are more blood vessels, so the chances of bleeding are more. So stick to the lateral side of the front of the thigh. Some people inject over the arm as well. So there also what you teach is look at the 2 bony prominences, the shoulder and the elbow. Divide that length into 3 and try to inject in the middle 1/3 between the shoulder and the elbow. So in the middle 1/3 you have to inject, and inject over the posterior half. So mostly your patient, let's say your patient is wearing a shirt. So then you say just inject between the crease of your sleeves and the stitching line of your sleeves. So towards the back. Why we ask for site rotation is because if site rotation doesn't occur, then you end up having something called lipohypertrophy. This is hypertrophy of the adipose tissue, and it occurs at the site of repeated insulin injection. It also occurs when we reuse the same needle again and again. So ideally, the needle should not be reused. When this lipohypertrophy occurs, it causes a rubbery swelling, a thick swelling, and this is relatively analgesic area. So when patients inject here, they don't feel any pain, so they prefer to inject here. But the problem is that there is less insulin absorption. So the insulin dosage goes up, the requirement goes up by 10 to 20%, and the insulin variability also goes up by more than 20%. If there is a patient where you are finding it difficult to control glucose, one of the simplest ways is to look for insulin site reactions like pain, bleeding, bruising, and lipohypertrophy. Just make sure that your patient begins injecting in the right manner into a healthy area. And this will help control glucose in many, many patients. So especially in people with type 1 diabetes, thin-built patients, children, people with very little subcutaneous tissue, spare time to teach them the right technique. Spare time to examine the sites yourself. Inspect as well as palpate. Make sure they avoid the lipohypertrophy. And then you will see that the results of glucose control will be very good. Lipohypertrophy can become quite visible actually at times. You can see it from afar. But even though you cannot see it, in many patients you will be able to palpate it. Some centers even get an ultrasound done to search for lipohypertrophy. So this must be done regularly. I would not advocate that we do ultrasound for everyone every day, but we should inspect and palpate the insulin sites at each visit. You should teach the patient how to self-palpate. The same way it's taught for breast examination, you should teach the patient how to check his or her own insulin sites. Early detection is helpful, but even more helpful is prevention, and that can be done by correct rotation and also avoiding reuse. Now, the vast majority of our patients will be on either pump, on either pen or vial and syringe, and this will be delivered subcutaneously. But this is multiple doses, subcutaneous. There are modern methods available now of insulin delivery. One is insulin pumps. That is also subcutaneous, but it is continuous subcutaneous. So here the style is totally different. You have to teach the patient how to use the pump, and how to do carbohydrate counting, how to adjust the doses. Connected insulin pens are also being developed. They are not available in India as of now. Development is underway, where the insulin pen is connected to the cloud. So if, let us say, the patient has injected 20 units tonight at 9 p.m. from a particular pen, everyone linked to that, the daughter may be living in San Francisco, the son may be living in Shanghai, they will get to know that their mummy has injected insulin 20 units at 9 p.m. Indian time. So this is the beauty of connected pens. Supposing I forgot, did I take my injection in the morning or not? The connected pen will remind me, yes, you did take your injection and you took it at this time. We also have good glucose monitoring systems, continuous glucose monitoring. And now, increasingly so, these glucose monitoring systems are linked with the insulin pumps. So these are called hybrid devices. Why they are called hybrid is because, number one, there is a little bit of glucose monitoring and a little bit of insulin pumping. So there's a hybrid of these. The second reason why they are called hybrid is because they are not totally automated yet. They are partly automated. So a little bit of uh, individual work is required. That is especially in terms of carbohydrate counting. You have to tell the pump how many grams of carbohydrate you have eaten or you are going to eat. So that you still have to do yourself. But still, these hybrid devices do help us in monitoring glucose and in delivering insulin. In India, we have good quality pumps available now. The best one is something called 780G, and the cost would be around 6 lakh rupees, with an extra cost of maybe around 5 to 10,000 rupees for consumables every month. Many apps are also available to provide self-management support in diabetes. One example is an app called My Sugar. You can link this with your glucometers. It's from a particular company, and these glucometers linked with My Sugar app are able to then give you your data in a very visually appealing manner, which makes it easy for the patient to understand, which helps the patient understand his or her trends in care, and which helps the patient understand how to adjust dosage and lifestyle later on. Do we prescribe these injections, these new pumps and automated delivery systems for everyone? Now, in an ideal world, the answer might be yes, we should advise to all, but it is not an ideal world. The first issue is with expense. They're quite expensive. The second issue is with education and enthusiasm of the patient. Is the patient educated enough? Is the patient enthusiastic enough to take these pumps and delivery systems? And the third issue is engagement. Are we able to engage with the patient? Are we able to spend the time that is required to explain all this? So because these issues are a challenge, the expense the education and enthusiasm of the patient, the expectation of the patient, and also the engagement level of the doctor and the healthcare team. Therefore, we suggest that pumps and delivery systems, automated delivery systems, should be used in only people with type 1 diabetes, others who need 4-dose therapy, who are not very well controlled on normal insulins, and those who have frequent infections or frequent complications of diabetes. It is not that if you prescribe an automated insulin delivery system or a pump, there will be no complications, there will be no issues. The pump will work only as much as you want it to work. So you have to follow the discipline. You have to enter your carbohydrate counts regularly. You have to adjust the insulin dose properly. So a lot of education is required on part of the patient. Not only that, there can be issues with the infusion pump. The infusion pump can get kinked or blocked. So therefore, ketosis decay can occur. Lipohypertrophy can occur with the infusion pump as well, with the insulin pump. How does this occur? With most insulin pumps, the recommendation is that you have to change the site every 3 days, every 72 hours. But if you don't change it, you continue with the same consumable for 5 days or 6 days, maybe in a thought process, with the thought process that you want to save money, you will end up getting lipohypertrophy there as well. A few patients, type 1 patients, use do-it-yourself closed loop systems. So instead of hybrid, they are doing a complete connection, and they close the loop between the pump and the glucose monitoring. You can do this yourself. It needs a little bit of technical know-how, but you should have a backup plan in case of pump failure, and you should keep your diabetes doctor in the loop as well. So close the loop with the diabetes doctor as well. We've spoken about insulin technique. Now, the beauty of this topic is, had I spoken about 10 years ago, I would have focused only on vials and syringes and on pumps. And I would have just talked about choosing the right needle, using the alcohol swab, avoiding needle reuse, and ensuring site rotation. We have done that today as well, but we are focusing on newer apps now. We are focusing on connected pens, on hybrid systems, on so many online tools. And this is the beauty of insulin technique, that it is influenced by digital health as well. Digital health is actually able to influence injection technique. So through digital health, you might wish to empower your patient to handle his diabetes himself or handle her diabetes herself. You might wish to engage with the patient through online coaching. You might say that I do not have the time to teach you everything that is required about diet, about weight loss. I cannot do it, but such and such a person can do it. So why don't you join an online coaching program for diabetes? And there are many good organizations which are doing this at a relatively economical rate. One good example would be Fitterfly from Mumbai. This online coaching and technology put together is actually helpful in managing pre-diabetes and diabetes and obesity as well. And when you use digital health technology, when you use digital support, you're actually supporting your patient to use the right insulin in the right manner, with the right technique, to achieve the right outcomes. Let's move on to our question for today. We have one question today. In type 2 diabetes treated with insulin, sorry for the typo, which of the following statements is true? In type 2 diabetes, is it that the insulin is always given once daily, or always given as multiple daily injections? In type 2, you do not have to match the dose with the amount of sugar and starch. Is it true that in type 2 diabetes, patients should not be treated with an insulin pump? Or is it that there are many different ways the insulin may be prescribed? The insulin dose regimen should match the patient's specific needs. So which of these is correct in type 2 diabetes? A, insulin always given once a day. B, insulin always given as multiple daily injections. C, you do not have to match the dose to the sugar amount. D, you do not have to treat with a pump. E, there are many different ways that you may prescribe insulin. The dose regimen should match the patient's needs. With this question, we come to the end of today's talk. I apologize that I am unable to take questions today, but feel free to share your questions in the chat box, and I promise to take them up next week. I once again request I ask for your permission to leave today, and I apologize once again. I will be taking the questions next week. With this, I'll hand over back to the FDC team today. Thank you and have a good day ahead. Jai Hind.